Welcome to a Long Covid Doctor, an educational series for sufferers of long Covid. I'm Dr. Tim Robinson, formerly a GP for 30 years, now GP lead for 3 NHS Long Covid clinics and a GP clinical lead in long Covid across southwest England. This episode is on headache and long Covid. In part 1, I will talk about the symptoms, the diagnosis, investigations and causes. In part 2, I'll talk about the treatments, management and outcomes. References, links and resources are in the show notes below. Any advice, diagnoses, treatments that I mention should only be considered after discussion with your own GP or qualified health professional. And so here we go. Headache and long Covid. So, firstly, the context, the background. Headache is a common symptom in long Covid. In my experience in the 3 long Covid clinics I work for, it is an extremely common symptom, having a great impact on those patients of ours. This may be the worsening of a previous headache or migraine tendency, or it may be just a completely new headache. Patients who've never had headaches in the past that are now occurring on most days for no reason, other than the fact that they have had Covid and they now have long Covid. And so, what are the patients experiencing? What are the symptoms and the associated symptoms? So basically, there are many presentations of headache. They can be severe or dull or crushing or throbbing or an internal pressure. These are all common sort of descriptions patients give us. They may be experiencing sort of a nail-like sort of symptom of pressure, boring in on the side of their skull. They may describe a sort of skull cap, sort of pressure bearing down on the top of their head, or a band around their head. The headache may be one-sided or all over, so unilateral or bilateral. Duration, well, that can vary. It can be either continuous or just lasting for a few hours or all day, but not at night. Patients sometimes describe actually waking up with a headache at night. How often? Basically this could be on a daily basis or every few days. It alters. It may be hormonally related. It may be related to for women, their menstrual cycle, particularly for their period is due on. There may be associated symptoms with the symptom of headache. There may be associated symptoms of nausea, feeling sick, or fear of the light, or visual disturbance. Patients sometimes experience a heightened sense of smell or taste or hearing, an extreme sensitivity of hearing, hyperacusis. They may see aura or, like I said, visual disturbance, as they know that the headache is going to, or specifically a migraine is going to come on. They may even weirdly have sort of changes in the bowel, or they may prompt diarrhea. Patients may have associated neck stiffness, cervical stiffness. They may have balance problems or vertigo or ringing in the ears, tinnitus. They may have sort of confusion and muddled thinking, difficulties with concentration. Sounds a bit like brain fog, doesn't it? Could be another cause for the patients to have the classic classic long Covid brain fog. And so, how do we go about helping? Essentially, we need to make a full medical assessment to get a diagnosis. We need to take a standard history and examination to get that diagnosis. Specifically, we're looking for possible differential diagnoses in which headache is a symptom. What are the causes of headache other than COVID? What are those differential diagnoses of headache? Well, broadly speaking, there are 5 common causes of chronic continuous headache rather than acute single one-off episodes of headache. The 5 causes, the commonest of the 5 causes, the commonest is tension headache. That is basically a band around their skull, sort of associated often with a neck tightness or the skull cap headache that I described, the sort of the bearing down on the top of the skull, a vertex headache. Often there's associated stress or anxiety or even sometimes even depression. And obviously in long COVID, that context, there's many reasons to be stressed or anxious and worried because of the effect that long COVID has had on our patients' life, the impact on their family dynamics, impact on their work, fears of reinfection, fears that they'll never get better. So lots of causes for worries and hence lots of causes for this commonest cause of headache, or a common cause of headache, and that is tension headache. The second common cause is migraine, and what we're finding is that patients had migraine before having COVID, they're finding that their headache, their migraine is now more frequent, worse since having COVID, now that they've got long COVID. Classically, the migraine headache is severe, usually one-sided, often preceded by a visual disturbance, an aura, usually associated with nausea or fear of the light or other symptoms like fatigue and dizziness, unsteadiness. There are many causes of migraine, but most basically thought to be due to the effects of blood vessels. This is the underlying, if you like, the underlying pathology behind that explains migraine. It's to do with the blood vessels being overreactive, dilating, expanding, and then contracting. So what we call vaso changes of those blood vessels, triggered by various things like chocolate or coffee or red wine or sometimes cheese. These sort of trigger factors bring about these changes within the brain and the blood vessels and the vasculature. It's important to treat migraine, as migraine symptoms really compound those long COVID symptoms. There are lots of similarities. So, as I've said, in migraine you have fatigue and you have a bit of confusion and cognitive impairment and dizziness. Well, those are symptoms associated with migraine, but obviously they sound horribly like the symptoms you get with long COVID. So there is this crossover of the two conditions. So therefore, the poor patient has double dose of symptoms. There are other types of migraine type of headache in this category, such as trigeminal neuralgia and cluster headaches. Leads on to number 3, the third cause of chronic headache, central sensitization pain. Basically, in the brainstem, in the middle and the depths of the brainstem, there are areas called the nociceptive, the pain receptor, the pain centers. And those pain centers become sort of overexcitable, hyperexcitable, and the pain thresholds at which they fire off, tell you you've got pain, are altered and they are lowered. And this leads to an increased sensitivity to pain, so-called hyperalgesia, and also painful perception of non-painful stimuli. So a non-painful stimuli is actually perceived as being painful, and this is called allodynia. Basically, these processes result in pain becoming fixed and chronic. That's the fourth. That's the big pun. Third, this is the fourth, the analgesia overuse headache. So if you take too many painkillers, too many paracetamol, you can ironically get what's known as an analgesia overuse headache, or paracetamol overuse headache. It's okay to use paracetamol 15 days per week. This is what the neurologists tell us, 15 days per week. Where that comes from, not too sure. However, I think the message is not on a daily basis. And if a patient is taking too much paracetamol, then you tell them to reduce and then stop, wean themselves off and then stop, this analgesia overuse headache basically resolves, clears within a couple of 6 to 8 weeks. And finally, the so-called chronic non-specific primary headache. Okay, this accounts for about 90% of headaches in primary care, in general practice primary care. It's sort of a global internal skull pressure type headache. So there we are. Those are the 5, if you like, categories or types of headache. Okay, so what do we do at this point? How to progress things? As I said, we need to take a history and examination. Firstly, the standard detailed history. What we want to know, what exactly is the patient experiencing? Everything about the headache itself, how often they're having them, how long for, associated symptoms, exacerbating or trigger factors, relieving factors, their impact on their activities of everyday living. Everything about the headache. We want to get a handle on it. It's relevant to ask about past medical history. Do they have a past history of headache or migraine or chronic sinusitis? Obviously, we want to ask about medication. Do they have a paracetamol overuse headache? So, is there a family history of headache or migraine? Very commonly, migraine is very common running in families. Having done the history, then it's on to the examination. Basically, an examination appropriate to what you found out in the symptoms and the history thus far. Focused especially on, so it's general, but maybe sort of focused on the neurological system. So you might want to do what we call a coarse neurological cranial nerve examination. We might want to look in the back of the eyes, looking for something called the optic discs, looking for papilledema. Maybe we probably want to do the pulse and the blood pressure. We probably want to, for completeness sake, palpate, feel the temporal artery. One of the causes for headache, one-sided headache, is inflammation of this artery here, the temporal artery. So I think it's important to include that in a general examination. If someone's saying they have one-sided headache, we probably want to examine for any pressure points, any tender spots on the skull or the base of the neck. Want to examine the neck to make sure the range of movement of the neck is full and equal. Make sure that the neck is not chronically stiff, and maybe look for radiation of pain extending down the arm. That's helpful to know. Just thinking other causes of headache emanating from the neck, cervical vertebrae, and then going up into the head. Basically, if there's pain going down the arm, when you move the neck, it points towards a nerve root compression in the neck. So, there we are, the history and examination. And the reason why we have to be so thorough is to look out for red flags. So, what's a red flag? A red flag is a symptom or sign that suggests something more sinister. So general red flags, sort of unexplained weight loss, or recent massive progressive weakness, or one-sided paralysis, a positive fast test, thinking stroke, massive recent personality changes, inappropriate behaviour. All of these need referral to hospital because they are sort of, if you like, in the bracket term, red flags. So need hospital referral at a pretty soonish basis. So those are the sort of the general red flags. Red flags specific to headache, we'd be a bit wary of a new onset headache, or beware of that, especially if the patient's never had it before. So a sudden sort of new onset headache. If it's sudden and it's severe, we'd be wondering whether the patient might have a so-called thunderclap headache due to a burst blood vessel, a subarachnoid hemorrhage. Like I said, those sort of headaches that are one-sided and associated with tenderness of the temporal artery, we'd be thinking of temporal arteritis. Important to ask sort of the hospital physician's opinion on, because inflamed temporal arteritis can lead to blindness. We'd obviously want to be aware of an extremely high blood pressure, thinking something called malignant hypertension, perhaps due to something called a pheochromocytoma. In my 30 years of general practice, I only saw one, but I did see one. And that patient had a young man, incredibly high blood pressure for no obvious reason. Something's not right there, and he turned out to have a pheochromocytoma. Obviously, abnormal neurological signs, those are sort of neurological red flags. One-sided weakness. We've talked about speech, thinking, talked about stroke. If the speech has become word-finding problems, or saying the wrong things, dyspraxia, dysphasia, nominal dysphasia, sensory or motor dysphasia, double vision, balance problems. We basically obviously want to be referring the patients with these symptoms or signs off to the neurologist pretty quickly. But more often than not, it's often an impression that you get. Like anything in medicine, we have to rely on our instinct. Just ask ourselves, does this feel right? Is there something not quite right here? Sort of using intuitive medicine. And so if this is the case, obviously we want to ask. So, how soon it depends on, how worried you are. It's all to do with the severity and the time course and the general features, whether you either pick up the phone, 999 or 111, or just advise the patient to see the GP. So, that's the red flags. So back to having taken the history and examination, it's on to investigations. Basically, anyone with long COVID, we're going to be wanting to do the baseline blood tests. This is what is in the NICE guidelines for management of long COVID. So we'd be wanting to do the full blood count, the kidney function, the liver function, the blood test for inflammation, the CRP, the ferritin. We'd be wanting to do the thyroid function test and the HbA1c if we suspect diabetes. Some patients ask for a skull x-ray if they've got a headache. It's really not really that helpful. We, as a rule, don't do skull x-rays in the absence of trauma. Neck x-ray, again, for patients with neck pain radiating up to the head, but basically most in anyone over sort of 35, it's going to show the beginnings of arthritis. So a neck x-ray is not going to be that helpful. But the majority of these patients with headaches, their investigations are negative. Some patients are keen to have an MRI scan, a scan of their brain, to look for something that might not be right, that they're fearing. Many patients worry that the headache is due to such an underlying condition in their skull. A brain tumour is the commonest worry that patients have. But it's nice to be able to reassure patients that there's a study that showed that less than 1% of headaches progress on to become diagnosed as a brain tumour. Or put it the other way around, brain tumours only present with headache in less than 1% of the patients. Majority of brain tumours present with neurological symptoms and signs mainly. It's important to tell patients this because it brings great reassurance. And while we're at it, other neurological conditions such as multiple sclerosis or motor neuron disease or Parkinson's disease usually don't present with headache either. Important to tell our patients that. Having said that about brain tumours, it's not overly helpful with regard to diagnosis of headache, and it's usually not necessary. I mean, MRI scan of patients with long COVID, can be positive, can show things. There's a cover scan, and there's a reference to that in the show notes below, that demonstrates that in patients with long COVID, they have a number of findings. They grey matter, where the cells of the brain is reduced, and there's a reduced volume in various areas of the brain, the hippocampus, where the short-term memory is, the prefrontal cortex, where executive functions, decision-making is made, is reduced. MRI scans can also show enlargement of the brain's immune system, the microglia, as well as, in another study, showed the mini blood clots in the brain, particularly in the hippocampus, where the short-term memory is. So MRI scan does have a place with regard to long COVID, but the question is, of course, how does it change the management of those patients with long COVID? Usually not in the slightest. So there we are. As long as we've ruled out the differential diagnoses of headache and the red flags, MRI scan really isn't going to be that necessary. Obviously, if there are concerns, the degree of headache is extreme, worsening symptoms, there are red flags, referral, as I've said before, immediate or soonish to the hospital. Acute care, the physicians or neurologist is necessary. So, we've reached the point where we've ruled out the differential diagnoses for those other causes of headache, and we've ruled out those red flags. We're left with, here we go, the diagnosis of headache due to the long COVID that the patient has. This is a good point to be at because, essentially we've thought about those other causes. We're not being so-called COVID blind. What do I mean by that? Basically, just because a patient or you've had COVID, that is not necessarily the cause of your symptoms. In this case, headache. It's not necessarily due to COVID. It might be due to any of those other causes. So COVID just happens to have occurred as a coincidence. So, like I said, we mustn't be COVID blind and say if someone who's COVID and they have a symptom, we can put it down to the COVID, the long COVID. No, let's be thorough about this and make sure we've ruled out those other causes. So, like I said, having ruled out those other causes, red flags, we can now make that diagnosis of headache due to long COVID. So let's drill down on that a bit more. I think that it's important to know the causes of long COVID headache, because it helps our patients understand and hence accept that problem. I think it also goes to remind our patients of the unknowns about headache as in itself, and also the complexities of long COVID, and all the things that can go wrong with long COVID, and hence the reason why fixing it is never going to be possible by doing just one thing. In this respect, there are two things to consider. Firstly, the headache in the general context and its causes, and secondly, the headache in the COVID context and its causes. So firstly, the headache in general, the causes. So headache and migraine is poorly understood. What actually happens in a headache? Why does someone have a headache? We've talked about the trigger factors and the different types of headache, but why is it that someone has a headache or a migraine for that matter? It's poorly understood. Headache happens when signals from outside or from inside in the body, in the head, arrive at a part of the brain called the thalamus. That's in the centre of the brain. It's the primitive brain. It's sort of like a relay station, which then sends signals to other parts of the brain that manage awareness of pain. The pain centres, the nociceptive centres I referred to briefly earlier. Not only is sort of those centres the awareness of the pain, but also the emotional response to it, as well as other parts of the brain that manage circulation and nausea and sort of ringing in the ears, tinnitus, and balance and bowel and bladder function. So something happens in that relay station, the thalamus, deep in the sort of the primitive brain, in sort of the heart of the brain, the brainstem. In the COVID setting, thinking headache in the COVID context, it's most likely to be multifactorial, because COVID is multifactorial, as we know, along with everything else in the body. Okay, it leaves damage. Damage is everywhere in the body, doesn't it? But it damages the nerve fibers and the blood vessels in the brain. A neurovascular problem, neurovascular brain blood vessel problem, neurovascular. And so it's little wonder that leads to headache and migraine in long COVID. In slightly more detail, just to remind ourselves, the COVID virus, the SARS-CoV-2 virus, causes loads of different things, doesn't it? Basically, it causes direct brain damage with the initial infection. So a form of encephalitis, that's inflammation of the brain, and results in brain fibre damage. COVID, the SARS-CoV-2 virus, causes dysregulated inflammatory response. And this is so complicated. The cytokine storm may be made worse by persisting virus lurking in the body, or activation of other viruses. Dysregulated inflammatory response is also due to mast cell activation. And we know that there are lots of mast cells dotted around the brain, particularly in the limbic system and brainstem areas. Then there's microclot formation in the brainstem and the limbic system. Like I said, we've seen that on MRI scans. All of these problems, this dysregulated inflammatory processes, result in inflammation of blood vessels. Again, neurovascular damage. Okay. And then there's dysfunction of the immune system, which leads to production of antibodies that attack our own normal cells, autoantibodies too. And they've been found. They're autoantibodies to brain fibers, to blood vessels and immune tissues have been found. That leads to more damage, more inflammation, yet more neurovascular system damage. And then there's dysfunction of the autonomic nervous system. Again, there are lots of reasons for this. Effect on the sort of the sympathetic parasympathetic balance, on the limbic system, autonomic limbic system, brainstem nuclei, plus the sort of the interaction and balance between the nerves and the endocrine or glandular systems. All this happens, and then there's dysfunction of the vagus nerve that then feeds into the brainstem, and leads to sickness behavior response, part of which is, wait for it, headache. There's a reference to that in the show notes below. A few more causes. SARS-CoV-2 is responsible for a whole load, isn't it? Basically imbalance of the gut microbiota, the flora, the friendly bacteria, which is so important for the general effect on well-being, immune system and gut-brain axis. More on that a bit later. And finally, SARS-CoV-2 causes an effect on our mental health. Again, why is that? Because both directly and indirectly, and like I said earlier, the effect of having long COVID, has so many ramifications, and leads to worry, stress, anxiety, and then contributes to tension, headache. So lots of reasons. Like I said, it's complicated. It's very complicated. So one person may have one of those processes happening, or two or three, or all of those processes happening, leading to the symptoms of their long COVID. So it's little wonder that long COVID causes so many symptoms across so many systems throughout the body, including the head. And hence, headache is such a common symptom in long COVID. It's complex. It is, I've said it before, the perfect storm. So, what is happening? That is what's happening, the perfect storm. So many things are happening. It's important to know all these things, both specific as well as general, as it helps us understand, helps our patients understand, and hence accept the process. And what is more important to our patients is, what is more important to our patients is, what are we going to do about it? Well, I'll come on to that, the treatment and the management of long COVID in long COVID headache in the second part. As I said, that basically concludes my first part on headache and long COVID, the symptoms, the diagnosis, investigations, and the causes. In the second part, like I said, I'll talk about the treatments, the management, the outcomes. I hope you found that helpful. As I mentioned at the start, any advice, diagnoses, treatments that I mention should only be considered after discussion with your own GP or your qualified health professional. So, in the meantime, I wish you well in your long COVID recovery.